All right. Hopefully you guys had a good weekend. Enjoyed your weekend, studied. All right. Remember, test one is over. Uh, Digestive and metabolism. Okay, so we're kind of jumping ahead with blood because we missed a day of class. So make sure as you guys are studying or preparing, be mindful of that. Right. Remember Wednesday, be on time. Make sure you have your green Scantron pencil. Okay. And make sure you guys space out in the room when you get here. We have a big room, so there shouldn't be a problem at all. Right? 30 multiple choice questions, 20 short answers. Remember, I don't need novels. Just get straight to the answer. Okay? It makes grading easier. Plus, you guys don't dig yourself into a hole. That's usually what happens. Student writes too much, they start to write the wrong thing. They contradict themselves. So just be mindful of that. Oh, is my video not working? Huh, that was interesting. Don't know why I did that. All right, so continue on with blood. All right, so when we generate red blood cells, they come specifically from the red bone marrow. This bone marrow, the main cell, the hemocytoblast is referred to as pluripotent. That means it can become many different cells. So that's that next statement. It can differentiate into the different types. When we're making blood cells, that is hematopoiesis. So we are generating white blood cells, red blood cells, megakaryocytes, which will become platelets when we break them down. So when they do a bone marrow transplant, that's what they're doing. They're pulling that and giving it to the patient. They have to radiate the patient or give them medications to kill off their bone marrow before they can do the transplant. So we must kill it off completely before doing the transplant. There's high rejection rates, so it's not like the safest thing to do per se, but sometimes we have to do it if they have like leukemia. The cells aren't functioning properly, they're not being created properly, and so we have to basically start over with a transplant. There is constant rejection. So when patients have to get transplants, the body is trying to reject it. It can still, even though they're a match for the transplant, the body can still identify it as foreign. There is still like sub-level of what we identify for matching purposes in organs or transplants that they must be on immunosuppressants. When these patients, do bone marrow transplants or in the hospital for extended periods of time, no contact. My wife had a coworker. It happened during COVID, developed leukemia and had to get a bone marrow transplant. She was in the hospital. I think it was like 6 months plus, a little over 6 months maybe. No contact. Couldn't husband, kid, no contact. No one could get in. So it was pretty tough. Rough time. All right. So hematopoiesis happens only in the long bones of adults and spongy bone, flat bone. So like in the skull, you could find a little bit there happening. It is mitosis, and they will differentiate into the different types of cells. So here at the top of this chart is that hemocytoblast. When certain like chemicals like interleukins, these are chemical communicators, are released that can stimulate the production of these cells. So for example, interleukin 3, I always remember the 3 if you turn it sideways, stimulates the myeloid stem cells. Interleukin 7, if you turn the 7 upside down, it's an L, stimulates the lymphoid cells. So you may have seen on TV, uh, there's like a commercial for a drug, and the lady's wearing like something on her arm here, and it says, after chemotherapy or radiation, you don't have to come back to the hospital for medications. What that is it's an interleukin, and it'll auto inject and then deliver the drug so they can start to make their cells and not go out in the environment and potentially get sick. So pretty neat tech that they're doing nowadays. Um, we also stimulate lineages using erythropoietin. We'll talk about that EPO that stimulates red blood cells specifically. Okay. And when we look at these different lineages, we're going to see lymphocytes. There's actually three subtypes. CD4, which is our T helper, CD8, which is our cytotoxic, and our there's four lineages. Our B cells, which become plasma cells, and then our NK cells, natural killer cells. So we'll actually see that cell has four subtypes when we talk about it in immunity. And their function is different for each one, right? What they're able to do, what they do for us. So we'll see that. Each of these cells, you're going to need to know how to identify them, especially for lab, and then know the numbers, the percentages. All right, erythrocyte, so that's a red blood cell, red blood corpuscle. When we look at characteristics, no nucleus. They initially did have a nucleus. They created the hemoglobin, and then they barf out their nucleus so there could be more space for oxygen carrying capacity. Your red blood cells live 120 days plus or minus a week. That's roughly the average lifespan of them. Your liver and spleen, because there's dense amounts of macrophages in there, especially the spleen, as the red blood cells are coming by and they're old and the cell membrane is like becoming fragile, they'll actually bite into them. They're called bite cells, and they'll consume them and will recycle the hemoglobin, the heme, bilirubin, and then the globin amino acids for protein structure. You'll see disorders in blood all the time. One of my friends has a pretty rare one of my good friends. He has thalassemia major, beta thalassemia major. His red blood cells live about 60 days. So he must get a transfusion every 6 weeks. He has to get a blood transfusion. He just cannot make enough. They had to take out his spleen so that he wouldn't degrade the red blood cells as quickly, let him live a little longer. Pretty wild disease. He has to take a medication that binds the iron to get it out of his bloodstream. So it's pretty wild. He collapsed on us one time. We were at a church convention. We were actually up here in Georgia when it happened. And we took him to a hospital, and the PA was standing there, and she's talking to him and checking him out and everything. And first off, he's got a nasty scar here from the spleen removal because I think they did it in Egypt a long time ago. And so the surgery wasn't as, nice as it is nowadays. And so she's like, "Oh, what happened to you?" And he's like, "Oh, I was in a gang fight and I got knifed." She's like, "Oh dear." He has a sense of humor. And then they needed a urine sample, and because of the amount of bilirubin that he's getting rid of, he was like, "Oh yeah, my sample, it's the one in the bathroom that looks like iced tea." And I kid you not, it looks like iced tea. We saw it. Very dark from all of the iron he's getting out of his body. So he takes iron chelation pills, like tablets that he dissolves in water, and it'll bind the iron and help get it out of his body. Because too much iron actually poisons you, poisons the organs and whatnot. So pretty wild. All right, so here we can see as the red blood cells are being formed early on, there's the nucleus, and then eventually they barf it out and we form the immature, which is the reticulocyte, and then erythrocyte is the functional adult red blood cell. So where do we make it? Bone marrow. What stimulates it? EPO. Erythropoietin is released from the kidneys. The reason the kidneys are in control of this is if blood flow or blood supply drops to the kidneys, they're usually the first to go. They're very sensitive to how much oxygen is being delivered to them. So we'll see blood pressure control is from there. Did we talk about aldosterone? No. That's my path phys class. We haven't talked about that yet. We'll see, this release of hormones, the effect on blood pressure. Kidney is playing a role in that. Okay. When you are generating a lot of red blood cells, we'll see a lot of immature red blood cells, the reticulocyte. That is normal. That just means you're generating red blood cells. Now, like in my friend, for example, he has a lot of reticulocytes, and it's showing his body's trying to make it, but they don't reach full functionality, or they're limited amount of functionality, and that's why he always has a high amount of reticulocytes. So if oxygen is low, we have different reasons here. Say you've lost some blood for some reason. Oxygen carrying capacity is decreased. Your hemoglobin is low. Oxygen carrying capacity is decreased. And let's say you go high altitude. There's not as much oxygen, so you don't saturate your red blood cells as much. Any of those scenarios, or we don't cover it, but stenosis in the renal artery. The blood flow can't get passed properly, and we can see it in that situation too. They start to make more red blood cells. Or if you're a smoker. If you're a smoker, carbon monoxide binds to your hemoglobin, and you can't get it off. You have to wait till the red blood cell dies off and eventually get it out of your bloodstream. All of these affect oxygen carrying capacity. The kidney releases EPO. That stimulates bone marrow. We generate red blood cells. Once we have appropriate carrying capacity, we'll see EPO levels decrease. We have EPO as a medication. That's the one Lance Armstrong got caught using. The cyclist. He got caught using that. That's the blood doping. And it's synthetic. So like when we measure it, we know, or like when we check for it, you can test for it, the synthetic. You can see it in the bloodstream. And then what he did, he got smart, and he started harvesting his own blood. And he would have it stored. And then when it comes for an event, he put it back in himself. So what do we see? Hematocrits through the roof, counts are through the roof. Yeah, it's his own blood, but the numbers aren't right. So he was doing that as well, and he got caught. And the reason he's doing that is more oxygen carrying capacity, more cellular respiration, more ATP, more stamina, longer he can perform. You see a lot of teams do this when they go practice up in like Colorado. Why are they going to Colorado to practice? High elevation. It takes about 2 weeks for this process to happen. So there was also like that gimmick where they make the mask that you wear when you're like working out or something. You have to be like 2 weeks constant for EPO to start being released because you're low oxygen. Okay? Hemoglobin, so complex quaternary structure. So there are 4 globin chains. In us, we have 2 alphas, 2 betas as adults, and it binds oxygen. That's its purpose, binding oxygen. How much in males versus females is different. Body size, amount of muscle, all of that's going to play a role in it. Females, if they're having menstrual cycle, that's just naturally going to decrease them a bit in their amounts. Okay, so we see 13.5 to 17.5 for males, and then 12 to 15.5 for women. All right, so inside the red blood cell, there's that equation that chases us. Okay, this is how we carry carbon dioxide. What we do is convert it into bicarb. There's a bicarb buffer, right? So we're converting it. When it's bound, when oxygen is bound, it's oxyhemoglobin, and then when carbon dioxide is bound, it's carboxyaminohemoglobin. We're missing some letters in there. All right. So when we break down red blood cells, what do? Iron, we keep it. We don't want to get rid of it. We'll use it to make new red blood cells, for example. The globin, we're going to break them down to amino acids. We'll build whatever protein structure we want. And then the heme portion, the bilirubin, we get rid of that. So that's what leaves in our bile and in our urine, out of the liver, can be concentrated in the gallbladder. okay, but typically leaving the body. We do pick some of it back up, but not much. Polycythemia. So we're going to go, and then anemias. So polycythemia, increased number in red blood cells. What's causing it? So when you look at certain situations like primary causation, you're looking at like this bone marrow cancer. It is a direct from the cells causing the increase. A secondary causation is, so that secondary polycythemia, that is due to something else, it's causing the increase. So, when Lance Armstrong took EPO, or when you go and train in high altitude, that is a secondary causation. Okay? When you dive deeper into AMP, you learn about like paraneoplastic tumors. These are tumors in the lungs that'll release hormones and cause what looks like a primary disease. Okay? So it could release like EPO, for example, insulin, and they do some wild things depending on the tumor. Okay? The problem is, yeah, it sounds great to have extra red blood cells, but this is a fluid and you're putting stuff in it. You're putting solute. You could say cells are solute. And so what's going to happen? It becomes thick, viscous. It doesn't want to flow very well. Now the heart is working harder. You're pushing it around slower. So increased chance of clots, increased chance of congestive heart failure. It's not a good thing to be having. Okay? So anemias, we're lowering oxygen carrying capacity. That's the definition of anemia. Everyone always thinks it's, iron, not necessarily. Right? So pernicious anemia, this is an autoimmune disorder that is attacking the parietal cell. And so we no longer make intrinsic factor. So they no longer can bind B12. They no longer can form proper red blood cells. They develop what's called a macrocytic anemia. Right? If anyone ever tells you you're deficient in B12, you should have blood work done. And if your red blood cells look normal, you are not deficient in B12. Okay? So in these patients, we must inject B12. That's the only solution. I cannot take an oral because no intrinsic factor. Hemolytic anemia, these are red blood cells are being destroyed. So like that beta thalassemia major that my friend has, that's a hemolytic anemia. You also will see it in patients that have like mechanical valves in the heart. Because it is a solid surface, as the red blood cells hit it, they actually lyse. So we can see it in that situation. So there's destruction of the red blood cells. Aplastic anemia, so this is the bone marrow is being wiped out. And so we're not producing the cells. We can see aplastic anemia for a number of reasons. If you guys watched 90 Day Fiancé a couple years ago, and there was a girl that went to Australia, if you saw that episode, and she literally was carrying a duffel bag of Bactrim with her, antibiotics. She had idiopathic aplastic anemia. Idiopathic means we don't know why. We do not have a reason for why her body did this. So she's taking daily antibiotics to protect herself. You can see it due to certain medications. Lead poisoning can cause it. So there are different causations for aplastic anemia. And then sickle cell, the functionality of the red blood cells isn't there. So they'll sickle, they'll go into that like crescent moon shaped, and then they get stuck. See, our capillaries are so small, especially when you guys look at lung, you'll get an eye for them. A true capillary is so small that only one red blood cell can fit down it, and it passes flat through it. And what happens, your red blood cells will actually stack like coins. Like you take coins to the bank, get in the little, those little tubes. Same kind of concept. And they'll stack on each other and flow through your capillaries. Well, the problem is you get one that's like crescent moon shaped, it gets stuck. Everything gets stuck behind it. And so everything after that isn't getting oxygen. They go through sickle crisis. It's extremely painful. They have to take painkillers. Downside to this, we're causing a lot of addiction. My wife sees it all the time. They come in and they're like, oh yeah, only Dilaudid works. I'm allergic to morphine. And they know that is the game for them to get a stronger painkiller. But it really does happen. It really is painful. She had one, the guy, the guy came in at like 8 o'clock in the morning and he had an erection that wouldn't go down because the blood couldn't drain. And so the problem is there's no circulation, the tissue can die. They did some injections, it wouldn't reduce, and like I think 6 hours later or something crazy like that, they actually had to sedate him and do a couple hundred micro injections to try and dilate the vessels and get the blood out of there so the tissue doesn't become necrotic. All right, blood typing. Okay, let me switch to camera. Share. Share content. Camera. We're going to use the board for a minute here. There we go. So blood commonly confuses students. So we're going to look at it a couple ways. All right. Your red blood cells have antigens on them. Antigens are name tags. They're ways for your body to identify things. So everything out there pretty much has an antigen on it. That's how our immune system identifies self, foreign. It's something it can read. Sometimes it gets confused and reads it wrong, and that's a problem. That's autoimmune disease. Then it attacks it and we're in trouble. Or that's allergies. It misidentifies a food and thinks it's bad. Okay? So on our red blood cells, we have these antigens, these markers, these identifiers. So you have technically three. Everyone technically has three antigens. So I am B positive blood type. Okay? So I'm always positive. So I have a B. These first two antigens identify ABO, the letter that's your blood type. This one is for Rh factor. Rh factor is that positive or negative blood type. So either you have it, if it's negative, there's nothing there. See, we can't say, like when you talk about like in medicine and stuff, say you go to the doctor and they ask you, do you smoke? And you say no, and they're like, well, since they don't, I'm just not going to write anything. If someone comes and reads the chart after them, they're going to go, well, they never asked that question. So whenever it's a negative result, we must list it's a negative result. Same thing with the blood typing here. So if I was B negative, in reality, nothing's there, but on paperwork, we would have to write negative. Okay? So here, I don't know what type I am. I'm either BB or I'm BO. I could be either. O is another negative, absent, it doesn't exist. Okay? Antibodies are anti my body. They are circulating in the bloodstream and they're anti my body. Do I want to attack my body? No, right? That would be bad. So can I have an antibody against B? Can I have an antibody against Rh factor? I'd be in trouble. My antibodies would bind here, attack it, destroy my blood. Can I have antibodies against A? I have A antibody. Yeah.
Why is the middle one only either B or O?
It's this, no, it could be A also. We're getting there. Yeah. So the question was like, why is the middle one B or O? In me, because I am B positive blood type, I can only be that situation. Okay? So let's say I give blood to someone. I'm going to give blood to someone. Let's see. Okay? They have antibodies. Antibodies degrade over time. Like when you give my blood to someone, these kind of degrade, nor can I make more because we're giving just the red blood cells. They spin it down, get rid of the white blood cells. So we're not worried about it making more and technically attacking who I'm giving it to. So who can I give blood to? Be what? Be positive. You can always start with the same blood type. So we know he has no antibodies to attack me. Who else? There's a technicality there. Be negative, there's a technicality.
Oh,
You could give it once, you can't give it beyond that. You develop antibodies down the road to RH. And we'll talk about that. That's with like where the mother is in a negative blood type and has a child that's positive, the antibodies can cross and attack it. So they give RhoGAM. You may have heard of RhoGAM. Can I give it to someone that is O? So we'll say O positive, okay? What antibodies is he going to have? I can't see the chat. I see someone wrote on the chat. I just can't see it. Let me pull it up. Okay. He would have A antibodies. Anything else? And B. If I give him my blood, he's going to attack it. Right? His antibodies that are floating around, we're in trouble. Can I give it to someone that's AB blood type?
No.
I'm still this guy.
No.
What antibodies does he have? Can he have A? Can he have B? He would attack himself. Can he have against RH? No. So I can give to this person. He won't attack any of my structure because he has this, he has that, he has that. There's nothing to identify here. Okay. So the trick with this is I always draw it out. I draw what antibodies it would have. And then when we talk about donating, draw out the person and what antibodies they would have. You can't attack yourself. Okay? That's the trick with this. Remember, the antibodies in the person donating, they don't mean anything. They're irrelevant. Right? O blood type, in reality, nothing's there. In reality, actually, let's do this. If you are O blood type, there's actually not an antigen here. We're just saying O to clarify that we checked, there's no A or B. So O is absent of an antigen. If you're O negative, there's literally no name tag on your red blood cells. Because there's no name tag on your red blood cells, yeah, you make antibodies, but those disappear. We're not worried about them when we donate blood. So, who can you donate to? Everyone. That is our universal donor. That's why O negative blood is such high demand. What if he's O positive? Who can he donate to? Everyone that's a positive blood type. Right? Everyone that's a positive blood type can accept him. Technically a negative, yes, one time, but we don't do that. We really don't see that happening because the risk is I donate that blood, antibodies match up with the antigens, it clots. They go into what's called DIC, the ABO incompatibility. and they go into DIC, disseminated intravascular coagulation. Their blood clots everywhere, organs fail everywhere, and then they bleed out profusely. And they just keep on going through that cycle until they die, usually. Okay? So remember, when we talk about blood typing, glycoproteins, those are sugary proteins. That's the antigen. So if you're blood type A, you're A blood type. Okay? If you're B, you're BB or BO. So just to take that a smidge further, you guys may have seen Punnett squares at some point. So let's say I'm BO, but I'm not because I showered today. No, no, that was quality. And let's say my wife is AO. And let's say we decide to have children and make that mistake. One child, I'm going to pass on an allele, one chromosome, and she's going to pass on a chromosome, and they combine. I could pass on the B, and she could pass on the A. We could have a child that's AB. We can have BO, we could have AO, and then we could just have O. So that's where you get these children, like the parents are AB blood type, but then they're O. They're not adopted, okay? It's that secondary marker that can be passed on, okay? So when they talk about AB, they're having both antigens on there. The way the notes are written here, they're saying, oh, you just have A, but you could have AA or AO, BB or BO, okay? And then O, no markers whatsoever.
You said the glycoprotein is the
Antigen. Yeah, glycoprotein is antigen, one and the same. So here, that's what they're talking about in this chart. So like A is either AA or AO, B is BB or BO, and so on. So we must check the ABO, and then we must check RH, the two different things. Antibodies, it's going to be whatever they don't have. So if he's A blood type, he's going to have B antibodies. If he's B blood type, he's going to have A. Because he has both A and B, he can't have antibodies against himself. And because he's O, he does have antibodies against everything. And if someone is O blood type and you ever donate, they will call you all the time to donate, especially if you're O negative. If you donate, they'll tell you. They'll tell you. It's good to donate if you can. Sometimes you're not allowed to, stuff like that. Like I lived in Egypt for 6 months, and because of that, I'm not allowed to donate. There is too much Hep B in Egypt, to the point where they've just said if you've lived in Egypt greater than 6 months, you cannot donate. Flat out rule, which is pretty wild. Right? They're probably going to change that eventually, but yeah, that's one of their rules. Just they don't want to take the risk of putting it into someone else, and that patient then developing Hep B. All right. So these antigens, agglutinogens, all that means is why we call them agglutinogens. Glutinogens. I'm going to brain fart today. When agglutination happens, when you have an antigen and antibody combine, and what happens, they all stick to each other. That is clogging. Right? What did Leslie write? Last month they told me I couldn't go anywhere because I had RBC antibodies. What exactly does that mean? What blood type are you? A positive? I mean, you're going to have B. Everyone has antibodies. I'm not sure what they meant by that. You should have B antibodies, but anyone with A positive is going to have B antibodies. Not sure what they were referencing by that. That's interesting. Hmm. So in lab, you guys will do an experiment where we give you these little wells and you put the patient's blood in it. In well number one, it has an A. Then you have a B, and then you have a RH. So it looks, you know, something like this. You got a little A, B, RH. So the patient's blood is in there. Then what you put is a bunch of antibodies. If they agglutinate, then we know on the surface of his RBC, there's A, for example. So if we see clumping here, that means he has on the surface of his red blood cell, A. Because we put tons of antibodies in there. So we're looking for the agglutination. That means the marker is there. If there's no agglutination here, then there's no B. If there's agglutination here, then he's RH positive. So he is A positive. Okay. The RH comes from, they discovered it in rhesus monkeys. That's how they discovered it. We knew about ABO, but we didn't know about the negative and positive initially. So that's what we're seeing here. We put a bunch of A antibodies in here, it clumped. A bunch of B antibodies in here, it clumped. So they're AB blood type. And so on. So O would have no agglutination whatsoever. So we use like synthetic blood and do that in lab. Pretty straightforward. So antibodies are anti our body, so we'll have it against anything that's not in our body. So if I have A blood type, I'm going to have B antibodies. If I have B blood type, I'm going to have A antibodies. Okay? Because the antibodies degrade so quickly, if you're O negative, you're a universal donor. You can give to anyone. And because they spin the blood down and the heavier red blood cells go to the bottom and in the middle, the buffy coat is typically where you see antibodies. AB has no antibodies. He won't attack anyone. When you're AB positive, you can take blood from anyone. You're a universal receiver. So here they're showing antigen on the surface, type A, antibodies, B. Draw it out. Don't try and memorize it. Trying to memorize the chart is so hard. Okay. Blood transfusions, all we're worried about is recipients' antibodies and donors' antigens. Do they pair? We can't donate to them. If there's no pairing, no matching, then it's safe. I cannot have antibodies in me to whatever blood's coming to me. If I do, it's going to agglutinate. We're going to be in big trouble. So here's what happens. There's that agglutination, that clumping, if it's a mismatch, ABO mismatch, and eventually DIC. They bleed out, use all their clotting factors. So they clog, unclog, clog, unclog. You give them blood. It's not a high survivability rate. That's what happens in Ebola. That's why they bleed out of like every orifice. You see it in after a woman delivers a child, amniotic fluid gets in to her bloodstream because it has the child's cells in it. We can see that happen at that event. I know 3 people it happened to, 2 died. 1 survived, but she had like massive perfusion protocols done where they were just dumping full amounts of blood into her several times. She barely survived. It's not anything anyone did. It's just that is a risk of delivery. Right? And then we see it, what else? Toxic shock syndrome. So when a woman wears like a tampon for too long, we see it in that event too. That's DIC as well. You can see it in a couple different situations. So blood transfusion, we got a couple questions here. Can a person with type A blood donate to type B? No, because that B person has A antibodies. It's going to attack it. Can a person with type A blood donate to O? No, because that person with O is going to have A and B antibodies. So he cannot receive either. And then can a person with A donate to AB? Yeah, because AB can't have antibodies against A or B. Remember, they are separate. If they did, they would attack themselves. So a person with A blood type can donate to AB. A person with B blood type can donate to AB. A person with O can donate to AB. So O, no markers on it. That's why you can give it to anyone. There's no name tags. So we give them to anyone. O negative specifically. Okay. All right. AB blood. He can have antibodies against anything, so he's our universal recipient or receiver. He can take from anyone. Nothing to attack. So here's a chart, like if you're A positive, who you can give blood to, who you can receive. So this is good, like as you're practicing, do it the way I did on the board. And then if you want to reference the chart, just check yourself to confirm that you're doing it correctly. All right, positive and negative. So that's that Rh, that D antigen or Reese's factor, Rh factor. If it is present, you do not have antibodies to it. If it is negative, you could have the antibodies to it. Okay? You don't develop them until you're exposed to a positive blood type. So, yes, technically you can give positive blood to a negative person. I could take B positive and give it to B negative. Technically, yes. But I don't know if they were ever exposed to blood that was positive blood type and developed the antibody. So we won't risk it. Okay? That negative blood type is going to get a negative donor giving to them. So if you're A negative, you're going to receive A negative or O negative. Okay? So O negative, nothing. That's why he gives to everyone. O positive, he has, we could only, because he has that positive antigen or Rh, D antigen, we can only give him to positive blood type people, right? So hospitals and stuff love O negative. If someone comes in and it's an emergency, they're bleeding out like crazy, we don't have time to blood type them, we can just give them O neg, right? You can just dump it into them and you're not worried. Nothing there to be attacked. So in like, dire situations, that's what they go for. So typically before like surgery, they'll blood type you. So they know in case something happens, what blood type you need. So they don't waste like that O negative if you're, AB positive. So here's the problem. Let's say the mother is a negative blood type. My mom actually was. She's A negative. I'm B positive. I don't even know why I know I'm B positive. I don't know. I don't even know how I read. I'm B positive, okay? I must have gotten blood typed at some point. Anywho, we have a problem. My mom, after delivering me, could have been exposed to my positive antigen. And she'll develop antibodies against that positive antigen or D antigen. The next fetus, her blood, these antibodies that are in her blood will cross the placenta and attack the fetus. So this is referred to as erythroblastosis fetalis. Child typically dies in utero because their blood is attacked. They can deliver it. They can deliver. They can make it sometimes, deliver, and they actually they kill off the child's bone marrow and do a transplant from the mother, and they actually switch the blood type. It's the only time we do that. Blood type of the baby changes to a negative blood type. It's pretty wild. Right? So what do we give? We give Rogam. Rogam is a drug that prevents the mother from developing the antibodies. It protects her from developing the antibodies. So they typically give it, I want to say it's month 3 and right before delivery. They'll give Rogam to prevent her from developing the antibodies. Uh, Once again, 90 Day Fiance. So there was one lady, she was a little wonky. She's the one that did the home delivery, if you guys watched it, insisted on it. And she was talking about she had a child, she was pregnant before, and she said, my blood attacked them. She had erythroblastosis fetalis. But she was saying it's her first child. Well, she could have had a failed pregnancy before, or an abortion, or a blood transfusion. We don't know. So that's why, in these situations, like, even though the first child shouldn't be affected, they should give Rogam to the first child, or the first pregnancy, during the first pregnancy. That risk factor is always there. We don't know the history. The mother may not realize it. Maybe when she was, 6 months old, she needed blood for some reason, and the parents never told her. So that's why here in the States, we give Rogam to any negative blood type mother. You're probably going to see this as you guys go out and about into your careers, because we're seeing a lot of, I want to do home delivery. I want to have a doula. I do not want to go to an OB-GYN and get blood tested, checked for this kind of stuff. So you're gonna see it happen potentially. The risk is there, which is kind of wild, right? So how do we avoid it? We give Rogam, just a shot, and it helps protect the mother from developing those antibodies.
Oh, they give it to everyone?
Any mother with a negative blood type. So yeah, anytime you get pregnant, that's one of the things they'll do. They'll blood type you and verify if you're a positive or negative blood type. So these terms, we've gone through all of these. Make sure you guys go through them. You're familiar with them. You can identify them. Like if they use it in a question, you're not getting thrown off. Right? As far as numbers, how many red blood cells, hemoglobin levels. You should be memorizing these, pH of blood. All right, white blood cells. So when we look at, general white blood cells, you can break them into 2 categories: granulocytes and agranulocytes. So they'll have granules in them. These are vesicles that they can actually secrete out, components inside of them like histamine, for example, and secrete it out. White blood cells all have nuclei, organelles, they function, they can react to their environment, they migrate around our bodies, they can actually react to chemicals and go to different parts of your bodies. As far as counts, you'll see 5 to 10,000. I think some labs will say 11,000. I think 12,000 normal. Just depends on the lab, what guidelines they're following, and that's why you can see the variation in normal white blood count. Okay. A majority of your white blood cells are actually not floating around your bloodstream, or they are stuck to your vessels, the walls of your vessels. And when we release those chemical communicators for some reason, let's say I get a wound and a white blood cell here starts to release chemical communicators, these guys will enter the bloodstream and migrate towards there. And they can respond pretty quickly to deal with just infection, cleaning up, whatever. So you'll see certain tissues have a lot in them, like lymph nodes, spleen. We house a lot in there, and that's why, in part, when you get sick and you feel your lymph nodes are swollen, these guys are cloning themselves very rapidly there, and that's why it hurts. So diapedesis, that is the ability to walk. They move. They squeeze through your red blood, your vessels, and migrate into the tissue. So that amoeboid movement they're referencing there, they move just like an amoeba. They can follow things. Chemotaxis, that's going towards the chemical attractant. So these are chemical communicators. It's almost like mini hormones, if you will. Phagocytosis, this is where they grow the pseudopodia, these little false feet, and engulf things. They bring them in and they kill them. That's one of their primary ways of killing. And then MHC, major histocompatibility complex. These are identifiers and communicators that are used between white blood cells. So we'll see there's MHC1, MHC2. They're strictly between certain cells on how they communicate. We talk about that in immunology. All right, so granulocyte and agranulocyte. So Ben has grains, like Uncle Ben, rice. Okay, so those granulocytes, those are vesicles inside of them. Things are stored inside of them that they can secrete out. So you need to know these percentages: basophils 0 to 1, eosinophils, neutrophils. Okay, know the percentages because the reason is neutrophils primarily deal with bacteria. So if a patient comes in and we draw blood on them and we look at a differential of their white blood cells and I see they have 85% neutrophils, I know they have a bacterial infection or they recently had a bacterial infection. So these alterations in numbers is important because clinically it helps us identify what they have going on. If I see a decrease in their lymphocytes, you start to look at either recent viral infection that attacked the lymphocytes. Primarily, you start thinking HIV. That's what you're looking at. So agranulocytes, they do not have any granules inside of them. Right? So these colonies, they all come from this stem cell. Colony stimulating factors, that's what I was talking about earlier, where we talk about like interleukin 3, interleukin 7. These are to stimulate the lineages. This promotes them to make more of themselves. So when there is damage or these cells are responding, they can release these colony stimulating factors to promote the production of more of them. They're going to make more so they can battle. You think of these guys as like soldiers in your body. They are certain soldiers. They can do different things, right? Like you have like Navy SEALs, you have Air Force. Like they are different in what they do, but they all work together. And that's kind of how you look at your white blood cells. Okay? So there's granulocyte stimulating, colony stimulating factor. So that would stimulate all the ones, the Ben, right? It would help promote their production. How are we doing on time? Oh, we're good. Neutrophils, so most common. Why? Because it deals with bacteria. That's the most common thing in our environment. In micro, I always tell my students, there's more bacteria on you and in you than your own cells. It's everywhere. They're referred to as segmented or segs. And all that means is they have one nucleus, but it's kind of pinched off. So they typically have like 4 little globes in there, but they are connected. So there's like a little thin line right there where he's connected. You can see the granules in there, those little speckling throughout him. Those are his granules. So he has, for example, he has like bleach in him. He basically can barf that out and destroy things. So he'll respond to like antigen-antibody complexes and destroy it that way. He has oxidizing agents in him. The polymorphonucleocytes, because the morphology of the nucleus can look different. You got to remember, these guys are 3D structures. It is a ball. So when we catch it, when we're looking at it on a slide, it looks 2D, it looks flat. How we catch it will alter how that nucleus looks. Okay, so when we talk about like test purposes, we'll always show you textbook looking one. Don't try and learn all the bizarre looking ones. Focus on textbook looking. Okay. So when they're very young, they're typically non-segmented. They're called bands. think we have, yeah, there we go. Bands. And then you look at segs, these are the more mature. See, that's a bite cell. That is an old red blood cell that's being broken down. Looks like a little bite was taken out of them. So neutrophils, first line. Why? They have all these oxidizing
Hello?
agents in them. Yeah. Hello? Someone chimed in for a second. Okay. Probably accidental. It's all good. So they phagocytize things, they eat them. And then usually what they'll do is they take the phagosome, the bacteria is inside a vesicle here. They'll take a lysosome, fuse it, and then open it up on itself and destroy that structure. When we talk about immunity, they then take the antigen that was on the surface of that organism and present it to our immune system to help train our immune system. Any phagocytic cell can do that. Eosinophils, these little guys, they're always reddish orange. When you guys look at them in lab, you look for this reddish orange. You can see all the inclusions in here, or the vesicles, the granules. These typically deal with worms, parasites, and allergies. So our system, what's happened is we're designed to be able to deal with parasites and fight them. But we live in such a sterile environment that it gets bored. And because it gets bored, this is where allergies come from. There is some component of genetic reason for allergies, but typically it is lack of exposure. We always used to tell parents, new parents, don't go near your child with peanut butter. Don't let them try foods. Wait till they're like older. And what we were discovered was we were creating the allergies. Because then when they come into contact with it and they're like 5 years old, their body goes, I've never seen this in 5 years. This is foreign. We must attack this. So now we tell parents when they're like, I think when the child's 3 months or 6 months, you eat peanut butter, you go near the child. The earlier we expose them, the less likely to see allergies. Right? Yeah, like I said, there is some genetic component to it. Like, for example, my dad is deathly allergic to fire ants. On my first sting from a wasp, I reacted. There's some type of genetic component there to where I reacted to it and had an allergic reaction. I got stung in this ear. This arm became massive. It was like Popeye, right? Made no sense. Okay. So yeah, what they're identifying is antigen-antibody complexes in your body. You'll form the two, and when they see that, they respond and they start to release their granules. I saw a patient once. We had to dilate his esophagus. I think I may have told you guys about this. He had eosinophilia, so he had reactions to food to the point where his esophagus had closed up. So we had to go in there and dilate it. He had to go to an allergist and figure out what he's allergic to and stop eating it. Interestingly enough, his mom had the same exact situation years before. So probably some genetic component there. Basophils, typically you don't really find these. You might find one here and there. Okay. These release histamine and heparin. So this is relating to inflammation. Histamine, vasodilator, heparin, blood thinner. Okay, just prevents like agglutination of platelets. So that's why you give like antihistamines. We load you up on it before, like Benadryl or Zyrtec or whatever, so that these cells do not degranulate. They don't release the granules. So this book says basophils and mast cells are different. I learned it as basophils are in the bloodstream, mast cells in the tissue. They're the same exact thing. They do the same exact job. We'll see that with monocytes and macrophages, Kupffer cells. That's just a monocyte in the liver, very specific. The Montoclast, singular. You may have heard of it, taken it. It basically what it does is it binds to these cells so that when the allergen comes into play, they can't degranulate. So they take it all the time. A really good drug for people with like seasonal allergies, stuff like that. It can really help. They just take it year round, and that can help. My wife and I, we take Claritin year round. It just the allergies. I never had allergies. I never had asthma until I moved to Georgia because it's foreign stuff. My body had never seen it. So I moved here and I started developing asthma and allergies. So I just take Claritin year round. Nothing wrong with it. Okay. Um, Anaphylactic shock. So anaphylactic shock is when we get a big grand amount of basophils and eosinophils degranulating. The problem is all your vessels go wide open, so your blood pressure goes whoop, your heart rate goes way up, and then to top it off, your airways close off, you produce more mucus, you cannot move air into the body, carbon dioxide out of the body, saturation of oxygen on the red blood cells is decreased, blood pressure is decreased, you are not delivering oxygen to the tissue, and it can kill. It's very rapid. How rapid people can go into anaphylaxis. I was watching something, it was about allergies on like Netflix or something, and the guy, he had gone to a restaurant, it was over in like England, and he told me, I have a severe peanut allergy, I cannot have peanuts whatsoever. And they're like, oh yeah, we don't use peanuts, whatever. They used peanuts. His roommate found he had taken, I think, 2 or 3 bites from his food, barely crawled across the room to the entrance of the bathroom, dead. Minutes. It can be minutes. Okay? So that's why a lot of schools are actually banning peanut butter. A lot of schools have banned peanut butter because little Johnny may not realize there's peanut butter in some friend's food, and they trade food and they go into anaphylaxis. And I get it, they may have an EpiPen there, but by the time you respond, it's in the nurse's office. You have this kid that's on the ground, can't breathe. All the other kids are seeing it's traumatic. Then the kid still has to go to the ER. So now it's an ambulance ride. The parents have to leave work. Like it's just chaos. Right? So typically, a lot of like elementary schools have actually banned peanut butter or peanut products. What's the protocol if you are allergic to diphenhydramine? Benadryl? It's pretty darn rare. There are situations like that, but it's pretty darn rare. I think that's where they just use Epi. I think they use Epi in that sense. But Natalie, you may be allergic to the brand. So there's a catch here. When you talk about like pills, they use certain binders to deliver the medication. Like when you think about it, you're taking a pill that big and it's 500 milligrams or something. There's lots of delivery agents, stuff like that. So it may be in that situation, it may be something in the IV solution. Did you like feel like you were lighting on fire, or did you go into like shock? What was your reaction, if you don't mind sharing? Wait for her to type. Yeah. So you were going into anaphylaxis. So epi. Usually they'll use like epinephrine in that situation. Just open everything up. But yeah, it's probably some component of the drug, not the drug directly. My wife had one recently. She's got some disorder, genetic disorder. She is on a IV drip around the clock of Benadryl. She had to hit herself with, I think it was 3 or 4 EpiPens because she was reacting. And so she came into the hospital, like, I think her heart was going a little fast. Okay. But yeah, she's sits at home and is on a drip. She's allergic to like everything, apparently. It's pretty wild. But it's due to a disorder that she has. Right? Monocytes. So these are the big Pac-Man, big old guys. They eat. And that's their big claim to fame, and they look kind of like Pac-Man. So these, when they're inside the tissue, they're macrophages. So we looked at one of these, and that was Kupffer in the liver. Those little guys sitting on the roads of the sinusoids. It's just a specialized macrophage in that area. So Kupffer, liver, microglia. You guys learn about AP1, Langerhans. They're all monocytes that are in that area of tissue. Functionality wise, they don't have the same skill set in reality. And then lymphocytes. So we're going to talk about these in depth with immunity. Big old nucleus, typically a sliver of cytoplasm. And we have two types of T cells we'll learn about, CD4, CD8, or T helper cytotoxic T cell. They have two names. B cells, when they're mature, they become plasma cells. And NK cells, these are untrained cells that typically deal with if they bump into something, or cancerous cells. These are the ones that kill off like cancer cells. So say a cell's going to undergo mitosis and it's mutated, something's wrong, it gets marked for death. Usually an NK cell takes care of it. So here's a nice little memory tool for you guys to help you, like, guide you with the percentages. So never let monkeys eat bananas. Just a helpful memory tool. So differential count, we talked about this. If we see these numbers altered, clinically they're telling us something. Okay? So high neutrophils, bacterial infection. Eosinophils, because they're responding to either parasites or allergies, it's telling us one of the two if we see it elevated. And here in the US, you're typically looking at allergies. You start to get concerned about parasites when you get people that travel overseas. They pick it up overseas, come back. That's usually where you see the parasite situation. Or they hunt. If they hunt, you don't really know what's on that food potentially that you're eating. There could be parasites in it if you're not like a seasoned hunter and know what you're looking for. Did y'all hear bird flu's back? I was just talking about it on the news this morning. So that'll be fun. All our eggs will get real expensive. Your chicken's about to get real expensive. They kill them off because they don't want it mixing with human flu, and then we get like some crazy ravaging flu that rips through, kills a lot of people. So they usually kill the birds off. That's what happened like a year ago. If you remember, eggs were silly expensive, chicken was silly expensive. That's exactly what happened.
What do you have them at home?
Yeah, it's probably fine. They're noticing it in the animals at this point. But the concern, wait, chickens? You have chicken? Oh, you have chickens. Ah, I mean, usually you see these outbreaks with the chicken flu, it's on the farms. Yeah. But the concern is, like, say you have the flu, you're in contact with them, those viruses can actually mix, and then you get a crazy strain of flu. Well, yeah. Random side note, since we're talking about immune. Okay. Leukopenia. So this is too few. Something's killing off the white blood cells, or we're using them. We're using them up for some reason. So typically you see when we wipe out the bone marrow. So that's the lead, arsenic, mercury poisoning. That's what you're seeing there. Radiation, we're destroying the bone marrow. And then overusage, measles, mumps, chickenpox, all of that could develop a leukopenia situation. So you have decreased white blood cells, you are increased risk of developing a secondary infection. Something else opportunistic is jumping in, taking over. So that's exactly what happens in HIV. They wipe out the CD4, they develop a leukopenia. They cannot protect themselves. You don't die from the HIV, you die from like the common cold. Something else. That's typically what takes you out. So that's why we try to maintain CD4 count as much as possible. And then leukocytosis, too many. You're reacting to an infection, so you're cloning cells. You can see it in that situation. Dehydration, because it's a measurement over volume. So when patients are dehydrated, it can elevate counts in general. And if they're overhydrated, it actually lowers counts in general. Okay. Emotional disturbances, because like cortisol release, so they can create more white blood cells because of this. So you can see it in situations like that. Stress, body stress. So it's responding to it. All right, let's stop there. I think that's a good stopping point. Any questions? No questions. So remember, test Wednesday. Be on time. Scan runs. Oh, we have a question. Yes. What's our question? Give her a second to type it up. So can negative blood donate to positive? But positive blood can't donate to negative. Correct. So when we look at marker, if let's say I am A negative, I technically will have antibodies against B and RH. But I'm not worried about these. Remember, these will disappear. So if I give it to someone that has positive blood type, so let's say A positive, he has that RH, he has antibodies against B and that's it. So there's nothing for him to attack on that. Vice versa, if I'm looking at this guy, giving to him, the problem is this guy has this to attack there. So negative can go to positive, positive cannot go to negative. Any other questions? Welcome. Cool. No other questions. I will see you all in person on Wednesday. Remember, room 110. So if you're not familiar with the building, it's when you come in the door, hang a left, the front door. It's all the way at the back on your left-hand side, or ask the front desk and they'll point you in the direction. Scantrons, pencils. I'll see y'all Wednesday. Bye.